Hi, thanks for joining us. My name is Jack Rerouting, and I'm a pediatric cardiologist at the Children's Hospital of Philadelphia. Welcome to Pediatric and Congenital Heart Talks, a series of lecture presentations and discussions on interesting and important topics in our field of pediatric and congenital heart care. In this series, we will share insights on a variety of topics, offer new perspectives on some basic principles, introduce novel concepts and innovations, as well as identify what needs to come next to solve challenging problems in our field. Our objectives are to provide education on a variety of topics, but also perhaps to stimulate some provocative thought on your part. We'd love to hear from you and to get your questions and thoughts on these discussions. You can contact us at this email address, chophearttalks@email.chop.edu. Okay, let's go ahead and get started.
Hi, I'm Joe Rossano, the Chief of Cardiology at the Children's Hospital of Philadelphia, and welcome to our Pediatric and Congenital Heart Disease Heart Talks. It is my pleasure today to introduce my friend and colleague from the Children's Hospital, Jack Rome, who will be speaking to us about catheter interventions for Fontan failure. Clearly, failure of the Fontan circulation is one of the most challenging clinical problems that we have today in congenital heart disease. And Jack is a world expert on this topic and has pioneered some of the interventions which have really changed the way we think about the care of these patients. Jack is a professor of pediatrics at the Children's Hospital of Philadelphia and the University of Pennsylvania, and is the former director of our cardiac catheterization laboratory and is our associate chief of cardiology for clinical affairs. He is a master clinician and expert in the field, and I look forward to his talk. Jack?
Thanks very much, Joe, and welcome everybody. It's a pleasure to have the opportunity to speak to you today. And as Joe told you, I want to focus on catheter interventions for Fontan failure syndromes. I thought we should start by framing the problem a little bit, and I think this study does a great job of that. This was published a couple of years ago, and it's a report from the Australian and New Zealand Fontan registry data. And importantly, we have to look at how they define Fontan failure, because one could define it many ways, but in this particular paper, Fontan failure was defined as death, heart transplantation, takedown or conversion, PLE, plastic bronchitis, or significant functional impairment. And in this series of data, they looked at outcomes in patients over time, and you can appreciate here that at 20 years of age, about 7% of patients met that criteria, and by 30 years of age, almost a quarter of the patients had Fontan failure by these definitions. And I think you might agree with me that this probably represents the tip of the iceberg, because many of us would add additional factors that we would consider failing Fontans, and we're certainly much more aware of things like significant liver injury with fibrosis leading to cirrhosis now. So we can all agree, I believe, that this is a major issue that we deal with. A number of years ago, we reviewed our experience just looking at interventional procedures in Fontan patients in general, most of which were either designed to treat or prevent Fontan failure. And you can see on this chart that there were many, many different types of interventions that were performed in a substantial number of patients. Well, it's clearly far beyond the scope of a single talk to cover all of these things, and I think it would be not particularly helpful to go into all those. And what I thought would be most interesting is for us to focus on one particular subset of issues, which really relates to the interventions on the total cavopulmonary circuit itself, and exclude for now the consideration of other things like fenestration, closure, and systemic arterial issues. So what I'd like for us to talk about today are the following. I thought we would start by discussing Fontan pathway obstructions, and we'll include broadly anything that might affect flow through the Fontan circuit, such as the baffle or conduit obstructions there, or the pulmonary arteries. And in the case of this conversation, I think that the interventions themselves are perhaps not so interesting. They're pretty standard techniques. But what I thought we might focus more on are discussions about what are the indications for intervening and what are the consequences of having obstructions and how we look at that. From there, I thought we'd move on to talk about something a little different, which is the way we can redirect or reroute flow in the Fontan circulation for treatment of things like pulmonary AVMs, and most recently for looking at ways to decompress the thoracic duct. So let's start by looking at the circuit, the Fontan circuit, and focus on Fontan pathway resistance generally. I think this work, which was done now over a decade ago, was really pretty groundbreaking work where the authors used computational fluid dynamic techniques from which they derived from MRI data sets to look at the impact of different flow conditions on the Fontan circuit. And what you see here is a sort of a diagram of a circuit, and on the bottom part of our diagram we have the systemic circulation, which we're going to ignore for now, and we're going to focus on the top part. And what we see here is the resistance through the total cavopulmonary circuit, and then the pulmonary resistance here. Now, we've all grown up to think about the pulmonary resistance as being one of the most important determinants of Fontan outcomes, but the groundbreaking work here was to show the significance of total cavopulmonary circuit resistance. So what the authors did was that they used their data set in about 20-odd patients, and they did a variety of CFD analyses, and they were able to show that the patients' TCPC circuits kind of stratified into three groups: a low resistance, this is the low resistance, a low resistance group, a group with medium TCPC resistance, and a group with high TCP resistance. And what you see here, if you plot resistance versus cardiac index, is that at baseline, what you might consider rest conditions, there's a significant difference in resistance, but what's most striking is that in the high and medium resistance cohorts, with increasing cardiac output, that resistance increases dramatically. And the reason I think this is important is if you think about the impact of exercise, exercise, of course, leads to an increase or a need for increased cardiac output. And what we know about increasing cardiac outputs is that typically pulmonary resistance will fall. But here what we see is that while pulmonary resistance may fall, TCPC resistance does the opposite. And in the same study, when the authors looked at effect of a changing heart rate on the cardiac output in these different circuits, low, medium, and high resistance, and compare it to a biventricular control, what you see is that in high resistance circuits, the ability of the circulation to increase cardiac output is dramatically limited. So this suggests that this problem of TCPC resistance may be a very important one in terms of functional capabilities of an individual with a Fontan circulation. Much more recently, the same group working with members of actually our program here looked at the correlation between TCPC resistance and liver fibrosis. And they did that by using MRI data sets from about 20 individuals with Fontans who had also had liver biopsy within a year of the MRI, and they evaluated liver fibrosis with perhaps one of the most sensitive techniques for doing that, using serious red staining on specimens. And what they found was that LPA stenosis and TCPC resistance were the two things in this, the two factors that correlated significantly with liver fibrosis. So taken together, it seems to me these data suggest that TCPC resistance is an important factor in functional status in Fontan patients and may well be an important predictor of long-term consequences. So this gets us to an important question, which is if we know that it's important to lower the resistance of the circuit, how do we determine when an obstruction in such a circuit is significant? This is a study by Tang et al. Published in 2016, also using CFD and computational fluid dynamic analysis to look at different conditions of Fontan flow. And what you see here is a three-dimensional reconstruction of one patient's Fontan circuit, and you can clearly see there's a significant narrowing in the Fontan conduit. What's notable is if you look at the top under the, this is the baseline anatomy, and you look at rest, the pressure drop through that stenosis is barely over 1 millimeter of mercury. And yet, when one subjects the circuit to simulated exercise, you can see that that pressure gradient rises to over 10 millimeters of mercury. Well, of course, this is the condition that we're measuring when we do heart catheterizations on these patients. So the point is that we may be measuring very low or virtually insignificant pressure differences. And the question arises, how do we decide whether or not to intervene on a narrowing? The authors went on to do a variety of regression equations, and were actually able to demonstrate pretty convincingly that if you have a narrowing that's less than about 10 millimeters in diameter per meter squared, that will correlate with significant obstruction to Fontan flow. So we start to have some criteria that we can use to think about when we need to intervene. What about the branch pulmonary arteries? Well, that's a good question. Unfortunately, we don't have this kind of data for branch pulmonary artery stenosis, but I think based on first principles, we could sort of at least come up with a rubric that we ought to work within, which is perhaps to say that if you have branch pulmonary artery stenosis that's anatomically evident, and if there's any pressure difference across that narrowing, particularly in the setting of significant flow discrepancy, that's a lesion that you ought to treat. So we need to be pretty aggressive at relieving obstructions in these circuits to minimize resistance. There is, however, one caveat that I think we all ought to keep in mind, and this, of course, comes from having fallen and made the mistake myself, which is always the best teacher. So here's an example of a patient who had undergone a Fontan after a hypoplastic left heart reconstruction earlier. The patient had significant left pulmonary artery stenosis with a very large neo-aorta. We aggressively stented that stenosis and thought we had done a reasonably good job, only to find the next day that the patient had significant chest pain and respiratory distress. CT angiogram demonstrated obliteration of the left mainstem bronchus between this huge neo-aorta and the stented pulmonary artery. Bronchoscopy shows complete occlusion of the left mainstem bronchus. Fortunately, this was able to be recovered with a temporary bronchial stent, and subsequently the bronchus remained open. And from this, we learned an important lesson. And the lesson is one needs to think about what else is around the vascular structures that one is stenting, and in particular, the bronchi related to central pulmonary arteries in patients with single ventricle reconstruction. So since that time, a very standardized protocol was developed where we perform intra-procedural bronchoscopy on any patient where we think the stent has a chance of resulting in bronchial compression, and it looks something like this. So you can see the baseline bronchoscopic view of the left mainstem bronchus here. The balloon is inflated down here, and you can see, so there's test inflation of a balloon catheter before one stents the stents the pulmonary artery. You can see the bronchus is a little bit distorted but widely patent, and this is one that one can safely go ahead and stent the pulmonary artery without worrying about bronchial compression. So we're going to switch gears now, and we're going to move into talking about catheter methods for rerouting flow in patients with Fontan circuits. The first thing we'll talk about are pulmonary arteriovenous malformations after Fontan. As you know, these are oftentimes thought due to the absence or maldistribution of hepatic venous return to the lungs, although the specific hepatic factor responsible remains unknown. We see this most commonly in Fontan patients who have heterotaxy syndromes, and probably the single most challenging group are those individuals with interruption of the inferior vena cava, often with bilateral superior cavae, who will have a Kawashima followed by some sort of a Fontan tube connecting hepatic venous drainage to the Fontan circuit. We can also see it in patients with discontinuous pulmonary arteries. The described treatment strategies for this are surgical, and that, I think, is the standard way of approaching it, and it involves some sort of a Fontan revision to redirect hepatic flow. There are a few published results, though there is one report from about a decade ago. And although the surgical reconstruction certainly can alleviate the problem, morbidity and mortality remains significant with the operation. The question arises is whether there was, or arose for us about whether there was a catheter strategy that one can employ to achieve the same outcome without needing surgery. Certainly, if such a strategy were possible, it could give us the desired outcome with less morbidity and perhaps lower risk. One can imagine, though, that anatomy would be required to determine the specific strategy. In some instances, it might be rather straightforward. For example, if you have discontinuous pulmonary arteries, in others, it could be very complex. So this is sort of, I would say, our index case, if you will, that led us to approach this. An individual, a youngster that had a heterotaxy syndrome, interruption of the IVC with azygous continuation to a left superior vena cava, bilateral cavae. The patient had undergone a Kawashima operation first, and then subsequently a Fontan conduit. The conduit was baffling the right-sided hepatic veins to the right pulmonary artery. And of course, not surprisingly, this led to significant flow maldistribution. And so if we look at this picture here, we see the hepatic veins coming up the conduit, and all that flow goes to the right lung. And so then when we inject to the left of that, we see flow from the interrupted IVC to the very large left superior cavopulmonary connection and diffuse AVMs in the left lung. So this individual had progressive cyanosis and indeed did undergo a revision of the Fontan with a conduit from the hepatic vein to the left azygos. Unfortunately, there was no improvement in saturations, and a follow-up catheterization demonstrated thrombosis of that conduit. The patient was discussed. The surgeon felt that reoperation would be too high a risk and that she just wasn't a candidate for that. And so at that point, the only therapy that was thought to potentially be effective would have been transplantation. So we did an MRI study, and this is the 3D reconstruction or the 3D model of that circuit with the flows superimposed and some measurements. And from this, we sort of came up with a way that we thought we could redistribute the hepatic venous return, and that's shown here diagrammatically on that same picture. So what you see here is a concept of a covered stent that's funneling the blood from the liver all the way across so that it can join with the venous return from the rest of the body, mix here, and distribute to the right lung, and most importantly, to the left lung. And then this is the actual procedure demonstrated here. So on the left-hand side, you see we have placed stents in the central pulmonary artery, one big one with two parallel smaller ones inside of it to serve as a scaffolding. This is a covered stent, a self-expanding covered stent called a Viabond graft. And then finally, another covered stent is telescoped inside that one, which will be further expanded at the bottom to completely seal off and redirect the flow. And that's demonstrated here. So on the left-hand side, you see an injection in the hepatic venous conduit, and you can see the flow going across through the midline, mixing, and indeed going predominantly to the left lung at this point, but also back to the right lung. And then here on the right, we see injection in the RSVC with flow going around that pathway. And we were gratified to see that this actually did result in gradual regression of the AVMs and a substantial improvement in the patient's oxygen saturation. Now, this is a rare problem. We reported a number of years ago a small number of patients. We've done more since, although only in modest numbers, but the results have been pretty similar. The baseline saturations in the group was at that time about 75% prior to intervention, and they were significantly impaired. All 4 procedures reported on were technically successful without major complications, and fortunately that has continued to be the case. The outcome then was about a 1.5-year follow-up median. Saturations rose to 90% on average, and New York Heart Association class improved. The 2 patients with the most complex type of rerouting along the lines I showed you derived perhaps the most benefit, actually. So that's an interesting problem, and one that we thought we were able to help a bit, but perhaps just as important as that particular issue was the confidence it gave us, or that opened the idea that we could actually do things to Fontan flow with catheters. And that led us to the following, which was transcatheter thoracic duct decompression for Fontan failure syndromes. Now, what is this all about? Well, in order to talk about this, we have to enter the realm of the lymphatic system and its role in Fontan morbidity. This cartoon here demonstrates normal lymphatic drainage. And what you can appreciate is that there are many, many streams of lymphatic fluid. There's the peripheral lymphatics, which enter the lymphatic system. The liver is a very important producer of lymphatic fluid, as is the gut, and even the lungs get into the picture too. It all joins the central lymphatic system through the thoracic duct, and most commonly will enter the left venous angle here. Well, what happens in the Fontan? Well, bad things happen in the Fontan when it comes to the lymphatic system. The Fontan physiology, or the Fontan circulation, is really a double whammy for the lymphatic system, because the first thing that happens is, as a consequence of increased central venous pressure, lymphatic fluid production goes up dramatically. And then the same increased central venous pressure results in a blockage of lymphatic drainage, because the lymphatic system is now draining to a higher pressure system. So this is a setup for problems, and indeed problems occur. We have plastic bronchitis, where instead of the fluid draining normally from the lungs, it goes backwards and lymphatic fluid goes into the lungs, so-called PLPS, or pulmonary lymphatic perfusion syndrome. And this results in plastic bronchitis. Or we have a similar phenomenon with retrograde lymphatic flow, but this time into the duodenum, and the consequence is protein-losing enteropathy. Now, there's been a lot of work by a lot of very innovative investigators, some of which you'll hear about in another one of these lectures from Dr. Yoav Dori, who's really been a pioneer in this field. And the consequence of that work has been dramatic improvement in specific therapies for these problems. So in the case of plastic bronchitis with embolization therapy, lymphatic embolization, they've been able to achieve 85 to 90% efficacy in treating plastic bronchitis. PLE is much more challenging, but the work has been really amazing, and the techniques continue to expand, and now efficacy is probably on the order of 70% or higher. So that's pretty dramatic positive outcomes. But what about the situation where you don't just have plastic bronchitis or PLE, but you have many compartments of lymphatic failure, so what we will call multi-compartment lymphatic failure after Fontan. PLE with or without plastic bronchitis, with ascites, maybe effusions on top of it. It kind of looks like this. Everything is going the wrong way. You can plug one thing, but what happens? Well, more drainage goes somewhere else. And the problem is you can't plug them all. We don't have ways to treat ascites, for example. So one is left with a patient that is chronically ill and not well treated. Are there alternatives? Well, this was really dramatically groundbreaking work published now 7 years ago by Victor Hraska, where approaching lymphatic failure in the Fontan rather than embolizing the specific leaks, his thought was, why don't I deal with the lymphatic problem a different way? I know that the problem here is that the lymphatic system can't drain because the venous pressure is too high. So can I get the thoracic duct to drain to a lower pressure circuit? And the way he accomplished that was by taking the innominate vein, detaching it, and sewing it into the right atrial appendage, which is in the pulmonary venous atrium. And he reported 2 patients in whom he performed this treatment. Both of them were undergoing surgery for other reasons, so this was not the sole indication for surgery. One of them had PLE, one of them had effusion and ascites. Both of them had a dramatic response. He's since gone on to publish an updated series just this year with similar excellent outcomes. It's still a modest number of patients, but nonetheless, dramatic improvement. Well, that's great, but unfortunately, not everybody is a surgical candidate. Some of the patients that we've encountered are far too sick, and sometimes anatomically it just can't be done because there's not enough mobility to get the innominate vein to the atrial appendage, or there may not be much of an atrial appendage to get to. So is there something we can do for these individuals? Again, could we accomplish the same thing by catheters? This is an artist's rendition of how one might do that in one of our first patients. This is the patient here, the MRI of the patient, I should say. And it's a typical Fontan circuit. It just happens to be in situs inversus. So we see a left-sided extracardiac Fontan. The patient has a right-sided innominate vein. And the concept that I drew here was just somewhat similar, reminiscent of what you saw for the AVMs, was a way to channel the flow inside the Fontan circulation with covered stents to the pulmonary venous atrium. We proved, first of all, that in fact the thoracic duct drained to the innominate vein. Obviously, that's critical knowledge. The patient underwent an embolization for PLE, but again, this was somebody who had multi-compartment lymphatic failure, and although the PLE embolization seemed to help, the ascites got much worse. We did MRI to look at all of the venous anatomy as well as the lymphatic anatomy. And then this is what the procedure looked like. So here's the baseline anatomy, just recapitulating what you saw on that MRI. The first part of the procedure involved doing a transeptal puncture to go from the Fontan conduit into the pulmonary venous atrium. Here's an injection simultaneously in the left-sided right atrial appendage and the innominate vein, showing us the relationship between the Fontan circuit and the appendage. This is now coming down from the left jugular vein, a transeptal puncture from the Fontan circuit into the atrial appendage, where there's a snare and a wire advanced through the transeptal needle and snared. And then that wire has to be switched, so it's a little exchange takes place on the left side of the screen so we can pull the wire out of the innominate vein. And on the right-hand side, we see the covered stent being positioned to go from the innominate vein through to the pulmonary venous atrium. And then finally here is the result. On the left-hand side, we see the innominate vein injection, opacification through that covered stent to the atrial appendage. And on the right-hand side, filling of the Fontan circuit. Now we can see that that covered stent is inside the Fontan circuit. This worked, and the patient got substantially better. And we went on to do this in a number of other patients. But I have to say, we weren't thrilled, I wasn't thrilled with having this covered stent inside of the Fontan circuit. So we went on to revise the approach, as you see here, in these next series of slides, and modify it. So here is a simultaneous injection, actually from 3 different places in this patient, showing us filling of the innominate vein to the pulmonary arteries, the left atrial appendage. This patient already had the transeptal approach, opacifying that, and then filling of the, actually a little later in the run, we'll see filling of the aorta itself. And so the concept here was to go extravascular with our covered stent, and that's demonstrated here. So here we see a transeptal approach from the left jugular vein going outside of the innominate vein here, and then traversing the distance to the left atrial appendage. And then here on the right-hand side, you can see the wire that has, after that's been done, the wire that traverses that distance. So we're going innominate vein, extravascular, a little bit of extravasation of contrast, wire course, atrial appendage, snare, and pulled out the body. And then finally, on the right-hand side, we see the stent being deployed to create that connection. And again, the result, here's the covered stent channeling flow from the left innominate vein, and on the right-hand side, you see the Fontan circuit remains unperturbed by this decompression. So current rubric, which continues to evolve, looks like this. We consider for this patients with multi-compartment lymphatic failure in whom the anatomy is suitable. Diagnostic evaluation is pretty extensive, so we have to do MRI to look at the cardiac and the lymphatic anatomy as well as physiology, diagnostic catheterization, and pre-procedure lymphatic embolization therapy if indicated. So far, 9 patients have been treated this way at a median of 7 years of age. And you can see the spectrum of lymphatic failure demonstrated here. All 9 had PLE, all 9 had ascites, and then several had effusions and a few plastic bronchitis. On a median of 3 compartments involved in each patient. 4 of them had the intrafontan tunnel approach that I showed you initially, and then 5 the subsequent approach or modifications of that. Fortunately, we haven't encountered any major procedural morbidity thus far. The follow-up is quite short, though, a mean of only about 8 months in 8 patients in whom we have follow-up. 1 of them did subsequently die from other complications. Reinterventions have unfortunately been pretty common, almost all of them endo leaks that develop around these covered stents that require sealing. But in general, the results have been pretty promising. Serum albumin has been normal in all but 1 patient. Lymphatic failure findings have resolved completely or almost completely in 5, although in 2 patients we have not achieved that result. So in conclusion, interventional catheter techniques play an essential role in the management and prevention of Fontan failure syndromes. Achieving the lowest possible resistance to flow should be the goal in every single patient who undergoes a total cable pulmonary connection. Rerouting therapy can be very effective in treating pulmonary AVMs due to maldistribution of hepatic flow. And transcatheter thoracic duct decompression can dramatically alter the outcome in patients with multi-compartment lymphatic failure syndromes. But it's worth emphasizing that our current data include only short-term follow-up on a pretty small number of patients, and we have so much yet to learn, including how to select our patients more appropriately, and obviously there's a lot more technical refinement that needs to occur. Thank you very much for your attention. I hope this has been a useful discussion for you.
Jack, thank you. That was a wonderful talk. Just really incredible work. And I did want to get your thoughts on a couple of things. One is innovation and how that comes about. I can remember the patient vividly when you first did, our team first did this decompression of the lymphatic system in the cath lab. And this was a patient that was incredibly sick. I think it's fair to say that the vast majority of people caring for this person did not think he would survive. Our surgery team wisely thought he would not survive a surgery, and I think most of us thought we were out of options in treating him. We discussed this patient in our surgical conference, and I remember you chime in and saying, well, I think we could decompress the thoracic system by, I could take a needle and poke it through the pulmonary arteries into the left atrium and put a stent in that, and we would put some covered stents in, and we would decompress the system. And I remember thinking, wait a minute, you want to stick a hole through the pulmonary arteries and into the atrium? Like, how is that going to work? And just thinking, like, this sounds like a crazy idea, and yet a brilliant idea, and one that frankly saved this patient's life. So how does that happen? How does that innovation come about? How did you think of it? And then, as importantly, how does one implement that? You've got an idea, you think, you know what, this could work. I've got a patient, they're out of options. I need to do this. I want to do this. So take us through this. How does that happen?
Well, I mean, it doesn't happen. I think, honestly, it doesn't happen in isolation. That's probably the single biggest point that I would say. I mean, it happens in a context. So you have, first of all, you have all of the people that have gone before you in a field that have come up with all these great techniques, right? Like, I didn't invent the transeptal, that was Brockenbrow. And I didn't invent stents. And I was taught how to use these things, or I learned from other people. And then, as I sort of emphasized in the talk, we had done some stuff with rerouting before. So we had gotten our feet wet with that. And in the case here, Yoav Dori, who's an incredibly innovative and iconoclastic thinker, was pushing for something like this as well. So, you have somebody who really believes it can be done. I wish I was more creative. I mean, I see people who are creative all the time, and I don't think of myself as being particularly creative. I mean, I try to draw something new or think of something new, and a lot of times nothing happens. But I have to say that for me, the thing that tends to make something happen is to be faced with a specific problem in a specific individual, and struggling with seeing whether, and it doesn't hurt to have somebody goad me a little bit, quite frankly, and say, well, I think we should do this. And you kind of go, oh, you're an idiot, we can't do that. But it gets you thinking, and you spend a lot of time drawing pictures and trying and saying, oh, that's not going to work. Well, maybe this would, and you kind of bounce it off of one person or another. And then you try to do due diligence, I think, try to figure out, well, what could go wrong? How am I going to approach that? Try to, in this case, use the tools you have available. Use MRI to simulate, well, will it work? Will the patient be too blue? Will there be too high resistance? We have all these fabulous people around with incredible expertise that you can kind of bounce things off of. So I think there are really people who are remarkable, who have brilliant ideas and are solo, they're flying solo and they come up with this stuff on their own. that's probably not me, honestly. You know, I mean, I need the environment around me and people to sort of push me a little bit and make me question my own biases and try to think of something new. And for the things that we've been successful with, that's kind of how it's gone.
That's great, Jack. I think there's a lot of lessons there for people and teams of, you know, trying to organize things, and you know fundamentally it gets to, you know, how do we push the field forward? And your statement of it starts with a patient and a clinical problem that doesn't have a good answer to, and this is a great example of that. And so I'd be interested in your thoughts of, your talk was wonderful, and the advancements are incredible and have clearly improved the lives of many children and adults with Fontan circulation. But they're still left with a Fontan circulation. And if we think of, you know, our goal for these patients, which is something like a normal life expectancy free from cardiovascular symptoms, which for a Fontan patient on a physiologic sense would be probably something like, can we achieve a normal cardiac output with low venous pressures? So where are we with that? And what do you envision for the next, I don't know, 10 years? And will we get to that goal, or what are the next things to get us to that goal?
Yeah, I mean, I agree with you. I think that's a great point. And my personal view is that we can do better with what we've got, right? We can hammer away and decreasing the resistance of the circuit, and we can use drugs to try to lower pulmonary resistance. But we have a fundamental problem, right? There's no pump there. And honestly, I don't see a long-term solution until we have a pump there. I mean, we need something to pump the blood through the lungs. And, you know, I don't for a moment doubt that we have the ability in the world and the expertise, the technological know-how to make this happen like now. But what we have is a problem of economics, I think, and will, if you will. And quite frankly, not to, I don't know. I mean, it's very sad. It's heartbreaking, if you will, to see that. But I think that's the solution. I think we need to have an energized circuit on the right side. And if you think about it, if we can do LVADs, which have to augment a lot more energy than this requires, it ought to be doable. But that's what I think.
Yeah, it's in some ways it's an engineering problem, or it in many ways could be an engineering problem, and certainly the engineering successes that have come from the concentrated effort of LVADs, as you allude to, has been, you know, just dramatic. The changes that we have seen over the last, you know, decade, even in the last 5 years with LVAD technology is just, you know, incredible, and that has helped so many millions of lives of mostly adults around the world. But how can we take some of that know-how and translate it into a pump for the right side, which obviously has its own complexities, but we've not been able to do that successfully, other than essentially case reports that have not really been a durable solution to the problem.
Yeah, and that's honestly because we are, people are using devices that were designed for left ventricular support and trying to modify them for a high flow, low resistance circuit, right? It doesn't work. I mean, you need a totally different kind of pumps, and I've seen some remarkable examples of things that I think really have tremendous promise, but we're talking about a relatively small number of potential recipients, and the question is, how does one get these ideas into actual production to help those people? And that's, to me, the greatest challenge that we face.
Yeah. Jack, let me shift gears if I can a little bit, and I'd like to get your thoughts on training and how does one become a master clinician? I mean, you are, if I may say, widely recognized as an expert cardiologist and an expert, catheter-based doctor. Right? You're expert in that, and there are many people who are, coming into the field now. And I can remember when I started as a fellow in cardiology, looking around at all of my attendings and thinking to myself, I could never do that. I mean, these people are great and I'm not that bright. So how do you do that? How do we get people that are getting, starting off in the field and turning them into experts? So what are your thoughts on that? You've trained a generation of doctors in the cath lab who are now leading programs around the world. How do you do that?
I don't know. I think it's mostly the people themselves. I continue to be amazed at the people who come through and we train, at how motivated and bright they are and dedicated, and they bring most of it with them, And I think, I don't know. I had great teachers, and they made an enormous impression on me, and it has lasted my whole career. But it's really the people who come in. There are so many of them who are just so dedicated that I think it's really just a question of giving them the opportunity to continue to grow, and obviously being dedicated to the effort. And we're blessed to have many people who are dedicated to education around us. I think it's vitally important. And then modeling what you think is important. I think that's probably the single most important thing, quite frankly. I think it worked when I was learning. I watched the way they did what they did and what they viewed as being important and what their priorities were. And, I was lucky enough to have incredibly great people teaching me, and they sort of complemented each other. There were two people in the cath lab at Boston Children's when I was training who had dramatic influence on me and impact on me. And they were incredibly different. One of them was named Barry Keane, and he is this wonderful Irishman who was the master clinician. He could, listen to somebody and pick out everything with his stethoscope. And in the cath lab, he was very slow and deliberate, but there wasn't a wasted move. And then I had Jim Locke, who was the other person in the cath lab, and was this young upstart who had just come there to run the cath lab. And he was the opposite. He was everywhere at once. Every part of his body was moving at all times. Catheters were flying all over the room. But he was phenomenal. And he was willing to try anything and everything and liked living life close to the edge. The two of them you would have thought would be oil and water, but they worked together seamlessly, and they valued each other and their expertise, and they were great foils for one another, and it was a tremendous learning experience. So I think, just trying to do the right thing and show that is probably the single best way to train somebody, in my opinion.
Yeah, that's great. And Jack, maybe lastly I could ask you, so I'm sure it has felt to you at many times, and certainly to your family, that there was no life that you had outside of cardiology. But I know you do have a life outside of cardiology. So how do you balance all the tremendous work that you do at work to other things at home and other things that you enjoy and unwind with?
Well, balancing is hard when you're in the thick of your career. Now, I'm in a slightly different stage in my career now. I have the good fortune of working with great people in the cath lab, and I handed over the reins of the cath lab directorship to Matt Gillespie, so I'm no longer the cath lab director. I don't get all those calls anymore, and I still work reasonably long hours, but not nearly as much as I once did. So I have a lot more time now. It was challenging in the younger years, and You know, Sue, my wife, is a pediatric cardiologist who's incredibly busy also, and doesn't look like any of our kids are going to be doctors, and I think that's not coincidence. I think they sort of looked at their parents and decided, yeah, maybe not. Maybe not, I'm going to do that. So I don't think we got the balance perfectly right. But I've all my life thought about the fact that, you know, I don't want to just be defined by this job, and I don't want this job to define me. So I have tried as best I can to do other things. When I was in training, which was in Boston, I used to watch the people out in those rowing shells on the river, and I thought that was the coolest thing I had ever seen. Now, I never rowed in school. I went to college in Ohio. The biggest body of water was like, you know, a swimming pool or something near us, except for the Cuyahoga River up north, which caught fire every year, so that wasn't a particularly good place to row. But then when I took my first job in Washington, there was this rowing, this place you could learn. So I picked up, I learned to row, sculling, those little boats you see, the little pencil-thin boats with one person in them. I flipped every single boat I ever rowed in. I was terrible at it to begin with, but I kept at it, and that's proven to be a tremendously great activity for me over the years. And, you know, every several years, I think it's really important to just do something you've never done before and that you're going to be really bad at and just take it on. So my latest effort is, you know, there's this wonderful place in Philadelphia called the Pennsylvania Academy of the Fine Arts. And they have courses, they offer degree programs. And so I started going there and taking classes. Unfortunately, COVID put a real damper on it because going there with all their plaster casts and these studios is a wonderful experience, and online is a pale comparison. But still, you know, there I am trying to draw, making a mess of things, and it's great. It's just really great. I think it's incredibly important to just try something new every once in a while. I think that keeps you engaged.
Well, that's great. And I think that's a wonderful place to end. Jack, great talk, impressive interventions, and I think a lot of optimism about the future. So
Thanks, Joe.
really appreciate it. Okay. Well, thank you, everybody.
And thank you all for your attention and for listening to this fantastic talk and life lessons and life advice. We are very much interested in your feedback, and we'd love to hear questions concerning our content that you've heard, as well as suggestions for additional topics that would be of interest to have reviewed in depth and discussed. In order to communicate with us, we have a dedicated email address. It's chophearttalks@email.chop.edu. We'd appreciate hearing from you. We'd love to hear your ideas and suggestions. Thanks so much for your attention.